Hi, welcome to the Deep Sea Foundation educational YouTube channel where we talk about all options for breast reconstruction and breast surgery for those affected by breast cancer. I am joined by Dr. Eric Wimmers, who is a board-certified plastic surgeon who specializes in microsurgery, practicing in Hopewell, New Jersey, at the Plastic Surgery Center. Dr. Wimmers has unique experience in microsurgery and immunology. His extensive research utilizing stem cells in hand transplantation has been presented nationally and internationally and was funded by the prestigious grants from the U.S. Department of Defense. Years of work in transplantation combined with 3 years of reconstructive training at the world-renowned Johns Hopkins University have made him an expert in microsurgery. Although he operates on the entire body, his special interests are breast reconstruction, like deep flap reconstruction, abdominal wall reconstruction, and peripheral nerve repair. Dr. Wimmers is a member of the American Society of Plastic Surgery, the American Society of Reconstructive Microsurgery, the American Society of Peripheral Nerve, and the American College of Surgeons. As a member of the IFAR network of surgeons, that stands for the Institute for Advanced Reconstruction, by the way, our discussion today is to bring access to care for patients considering breast reconstruction surgery. And of course, I will put links in the description so that you can find Dr. Wimmers. I'm really pleased, Dr. Wimmers, that you and I had a chance to talk to each other at the American Society of Reconstructive Microsurgeons this year in January. And I really want to thank you for joining me today. You've already done surgery this morning, so thanks for joining me on the channel today. I really appreciate it.
Of course, Terry. Thanks for having me. That was a nice introduction. I appreciate it.
Absolutely. Well, how about we begin by you just telling us briefly about how you became interested in microsurgery, plastic surgery, and why you've specialized in the treatment for breast cancer patients.
Sure. It was a pathway that developed over time. So I was always kind of envious of people in high school that knew exactly what they wanted to do and just had that pathway all figured out. I was not one of those people. It took me quite a while to kind of figure out what to do. It wasn't until I was in my second year of college, an undergraduate, I was at UCLA. And my major was undeclared. I wasn't even sure what I was going to major in. I was in my second year and I took an introduction to physiology course. And it really opened up my eyes. And it became so fascinating to me. One, that we had an explanation of how these microscopic structures in our body work, like how a nerve transduces the information, how an artery works, down to the cell of how ions are crossing the wall of the membrane and how it all functions. And not only just the magic of figuring that out and knowing that, but to me at that point, it was really an eye-opener that, wow, we actually know how our body works. Like, this is fantastic. And I was hooked. As soon as I took that class, I changed my major to physiology and I decided, okay, you know what, I'm not sure what I'm going to do with my whole life, but I'm going to start by becoming a doctor. Let me just figure out my own body first. And maybe eventually I'll get to a point where I, want to become a lawyer or want to be, broaden that experience a little bit. But that's how it started. And when I went to medical school, my plan going into medical school was that I would become an emergency room physician. That was kind of my idea. Had worked as an emergency room tech, and I loved just the excitement of the ER, the breadth of things that come in, and just it seemed really fascinating to me. by my third year of med school, I kind of realized that I could basically do emergency room work already. You know, it's kind of a handoff position, and it definitely has its benefits of being shift work and so forth. But what I started to realize was that I really like surgery. And I had some inspiring surgeons in my medical school, and to be able to put together all the information that we spent learning our first 2 years, all the textbook information, and put it into something that we could use with our hands and put it into function, that was super appealing to me. So at that point, I thought, okay, I'll become a surgeon, but I'm gonna become a trauma surgeon. Still kind of holding on to the emergency room idea of like the exciting, what's gonna happen next kind of feeling. That's appealing when you're 20, right? Um, and so I began general surgery, and in my third year of general surgery, still planning to do trauma surgery, I again became more aware of what trauma surgery was, and more specifically, what a plastic surgeon was. Up until that point, I thought, Terry, I thought plastic surgery was all lips and boobs, and I didn't really think much about it. It wasn't really a field that I had exposure to, and I just didn't know what it was really about. I didn't know that being a plastic surgeon is actually being a reconstructive surgeon.
Yeah.
And it wasn't until that third year in general surgery where I got some exposure to it. And I found out, this is actually what I like about trauma surgery. It's the second half of things. It's the putting things back together. And once I realized that, I was like, okay, now I know my life path. And so I switched gears, went into plastic surgery training. So I finished my general surgery first. I went to University of Pittsburgh and worked for 2 years in surgical research. So I was doing animal research, which was very fascinating. That's where I got exposure to the hand transplant team. So I was at Pittsburgh for 2 years, and then I went to Johns Hopkins for my plastics training. At Pittsburgh, that's what started my microsurgery. So the kind of projects we were involved in were really fascinating, both on rat models as well as pig models, taking one of their limbs and transferring it to another animal. So doing a hind limb transplant, which would mimic a hand transplant. And most importantly, what we were studying is how can we trick the immune system to accept this limb from another animal, right? And during there, I was part of a process that is called the Pittsburgh Protocol now, and it's actually used in humans. It wasn't something I developed independently, but I was part of the process that helped to establish that, where we can trick the immune system by giving an injection of the donor stem cells at this time of the transplant. We can cause a reset of the immune system for it to think, oh, this is actually my hand, not another person's hand, and really reduce the immunosuppression. So during that process, I was sewing these little vessels and nerves on rats and pigs, and so that's what started my microsurgery training. Even before my plastics training was in the lab there. What a great experience! I love animals, and I was worried, how's this going to feel doing animal research?
Yeah.
And it was a great experience. It was at Pittsburgh, and there was such a love for these animals. There was so much care. I was really impressed. So I had I don't know, the misconception beforehand that, if you do animal work, you're going to be mean to there was so much care involved for these animals to make sure they were comfortable and that they were taken care of. It was really a fun experience for me. And then
Wow.
once I got to Johns Hopkins, it was helpful to have that microsurgical experience already. So by the time we're doing real microsurgical cases, which we did a lot of at Hopkins, by the time I finished those 3 years there, I didn't need an additional fellowship. I was ready to go, and I started practice thereafter.
That's amazing. You know,
Yeah.
I I have to say, Eric, we didn't get this much, or Dr. Wimmers, I'm sorry, we
Yeah.
didn't get this much conversation in at ASRM. but I'm always fascinated with the trajectory and the inspiration that really gets you to the point, or to the point that microsurgeons who are treating breast cancer patients are at now. And so the beginning of your conversation about how the body works and the intricacies of it, form and function, how that
Yeah.
inspired you to do microsurgery is fascinating. So I'm really glad that you shared that with us, and it makes complete sense. Um, you know, ER versus what you're doing now, because I watched one of my own nephews go through his training, who's now an ER doc. And I
Yeah.
must say, we all find our niches in life, correct?
Correct. Yeah.
Uh, ER is a very frenetic and fast-paced environment. For you now, you are developing relationships with your patients. And a
Exactly.
lot of times it's long term. That
That's
has to
right.
have special meaning to you.
It is, and that's really the key thing that pulled me into surgery
Mhm.
was realizing that as much as ER was fun and gratifying and provides a really great lifestyle because it's a controlled work
Mhm.
situation,
Right.
um, that surgery was kind of opposite of that, right? It was not as much of a controlled life situation. You might get called in the middle of the night. You have a patient with a problem. But I also realized just what you said, that here is an opportunity to have real relationships with people, with my patients, and to have that longevity. And I just knowing myself, I knew that would be really gratifying. So I'm glad the
Yeah.
choice that I made.
Yes. So I'm to that point. I'm really glad that we can put the link to your work, because I encourage other people who are, finding you and finding your work to look at some of those stories. I looked at some of your videos from patients that you have done deep flap on. They're very beautiful videos, very touching. So be sure and check those out. So let's talk for just a moment. Talking about access to care. There are different ways to find you, and as part of this IFAR network, again, that stands for the Institute for Advanced Reconstruction. Um, that's another way to find you. You're on their website too. Can
Yeah.
you tell us about IFAR and tell us the benefits of being within that network?
Right. So I'm part of a group practice, as you were saying, and years ago, our practice, which is all surgeons like myself, very specialized plastic and reconstructive surgeons. So we're not the typical type of plastic surgeon that most people think of. We all do some cosmetic work. Some of us do more or less than others. I do hardly any cosmetic work, just out of preference. I really enjoy the reconstructive side of things. But people in my practice, there are other surgeons in my practice, we all have developed different types of niche specialties. So a lot of them in peripheral nerves, could be other areas. And that's where the IFAR brand comes in, is that
Mhm.
we wanted to really make a stance and a declaration of what we're doing that was special, so that really to make us stand out. Now that has evolved where we are grouping up with other like-minded plastic surgeons across the country. So there are other groups just like us who have the same kind of idea. They're like, let's do some specialized surgery. Let's help people that feel like there's no other solution for them, and try and find these kind of different, what we call orphan diseases, or things that people are just told, sorry, too bad you have that problem of post-mastectomy pain syndrome. Why don't you go see a pain specialist? But instead, we take something like that, post-mastectomy pain syndrome, can be a terrible thing,
Mhm.
and say, okay, well, what's actually causing it? So it's actually a nerve, a lateral cutaneous nerve that gets cut from the mastectomy and gets neglected, or there's some scar tissue forming on it. And so we've worked out over the years, this is a more recent project of ours, is a fix for that, where we do a nerve transfer and find that nerve, tunnel it over to where an intercostal nerve is and plug it in and give it a happy home to be. And guess what? The nerve, when it's happy, it doesn't cause pain. And it's so we take things like that. That's just one of many examples that we do. And that's what kind of falls under the Institute for Advanced Reconstruction. And now we're grouping up and joining with other like-minded surgeons across the country to become even a bigger group. So it's been really great, not just from what we've developed, but also giving a platform for other reconstructive surgeons to join us, and that could be as beneficial as just knowing there's other surgeons out there doing the same thing, to assistance with negotiation with insurance companies, like the whole gamut. It's been really effective. And so taking that idea, now associating with other like-minded surgeons across the country, now what we're trying to do is take it to the next level, which is to cross-pollinate some of these ideas. So, right, to take an idea that, say, we thought of that works really well, and tell a group in Ohio about what we're doing, and they tell us, well, we've got this technique for this other problem of capsular contracture or whatever it is. So that's now the stage that we're working on, and that's, as you know, and in any field, once you start having people talking on either side, ideas come up, you come up with solutions. It's been really great.
You know what I call it, from a patient perspective, who is very deeply entrenched in education all my life. I think it is a melding of microsurgical minds. And that, to me, that translates into a benefit for patients ultimately. Because when you guys are all in this network and you're sharing this information, and you have the capability and the pathway to do that, and you're putting all those wheels together, the insurance, the managing of getting the education and information out to patients, but most importantly, it's that sharing of your combined experience that I think is just very beneficial for patients. So thank you for that great explanation of that. I have a question, Dr. Wimmers. We talked about this offline via email. I frequently get inquiries from patients about using fat grafting only for breast reconstruction. Can you tell us who might be a candidate for that and what the benefits are for that for breast reconstruction?
Absolutely. So in general, there's a few different ways of going about breast reconstruction. I'm sure most listeners are aware that a silicone implant can replace the breast tissue. There's also a couple older techniques of rotation of tissue, or say like moving a muscle from the back, like a latissimus flap, still legitimate procedures. But there's some evolution in that regard of using your own tissue. And when we say using your own tissue, we call that autologous. So an autologous reconstruction can come in several different forms. The form that I do most is a deep flap, where I take tissue from the lower abdomen and I isolate the blood vessels and then bring it up to the chest, and using a microscope, hook that tissue up in the chest, so that it's the patient's own living tissue. If they gain weight, it gets bigger. If they lose weight, it gets smaller. And that's a really probably the most sophisticated breast reconstruction procedure currently. And it's great. It's a really rewarding procedure from a surgeon's perspective. There's some instant gratification of taking someone who is either completely flat or just has a temporary spacer in the breast and putting real tissue in that, and to get a instant soft breast from that procedure. That's really gratifying. But not all patients have the excess tissue in their own body in the right places, maybe, to do that procedure. And a deep flap is one of several different flaps that can be done. But I do get inquiries about fat grafting only. Um, patients who are interested in it for a variety of different reasons. It might be that they've already had a tummy tuck and they don't have the tissue for a deep flap. It could be
Right.
one reason. Or
Right.
maybe just their fat distribution is such that they have fat in other places, but not their lower abdomen.
Mhm.
Uh, Most of my inquiries for this, or at least the patients that I go on to do breast reconstruction with fat grafting only, usually end up being kind of on the smaller side. Their goal is to have a smaller size breast, like maybe a B cup breast, and
Mhm.
maybe they don't have a tremendous amount of body fat. And so with fat grafting, it's how it works is it's a relatively simple procedure. It's generally an outpatient procedure.
Mhm.
It's something I do fat grafting every week, multiple times a week. It's usually I use it 95% of the time for a touch-up procedure, like say after a deep flap to smooth an edge or adjust a contour, add some volume, just kind of a way of kind of remolding, reshaping the breast.
Mhm.
That's what I use it predominantly for. And when we use it for making a breast only, it can definitely be done. It just has some different challenges involved. So the first thing is finding the right patient who will fit this.
Mhm.
And the patients that I've done, I've had great success, and they've been thrilled with it. And what I really stress going into it is unlike a deep flap procedure where we're doing a big change all at once. The fat grafting procedures are small changes done over a series of surgeries. So that's really the key difference, is that it usually takes 4, maybe 5 surgeries to successfully build a breast up with fat grafting only. And here's why, Terry. When we do fat grafting, it's kind of like it's akin to like gardening. So when you say like you have a little sapling that you're trying to plant in your garden, um, that needs to be handled with care, right? You have to have the right soil. You have to make sure it's handled gently, give it the right amount of water, the right sun, all of those things. And it's the same thing with fat grafting. It's a very technique-driven procedure.
Mhm.
And I started to develop my appreciation for that actually when I was at Pittsburgh for some of the research we were doing, because we were injecting those stem cells into the hind limb transplants. And the stem cells we were using, so there's two good sources of stem cells. One is in the bone marrow, right? So you get that, you scoop out some of the bone marrow, filter out the cells, get the cells you want, and those are great cells. Another cell, which is more easily obtained, is in our fat, and they're called adipose-derived stem cells. It's a mesenchymal stem cell. What a mesenchymal stem cell does, it's a repair stem cell. And
Mhm.
so that stem cell can repair just about anything in our body. It can repair bone, it can repair an artery, it can repair a nerve, it can repair fat, it can become cartilage, it can convert into another type of cell. So these cells are really, really useful, fascinating cells. And there's a lot of great research on this type of cells. And in fact, your mesenchymal stem cells are the same as mine. And they're interesting that they don't have the antigen tags on them that say this is Eric's stem cell or this is Terry's stem cell. So theoretically, we could put those stem cells on a shelf and give them to somebody else. We haven't gotten to that point yet in our
Yeah.
science, but that is a potential future of it, right?
Wow. Wow.
And there's even some cool research where very solid research that's showing that if you do fat grafting, so if you inject these stem cells into a breast in particular, the
Mhm.
research is on, that it reverses some of the radiation damage. And it's
Yes.
because of these stem cells, right?
I
So
think, is this not why we call it liquid gold sometimes?
yeah, absolutely, absolutely.
Yeah.
So it's a very technique driven procedure.
Mhm.
And because essentially, you're not just injecting globs of fat. So
Mhm.
so how I think about it is what I'm injecting is the real good stuff, which is the stem cells which are in there. And I've spun them down in a centrifuge. I know that it's just like a very, very small amount of the actual volume is the stem cells, but it's a powerful part of that volume.
Yeah.
So when I say it's technique driven, what I mean by that is how the fat is handled, how much suction is used to suck it out of the body, how it is processed or washed, and how it's injected back in. There's research showing that each and every of those steps can determine how much of the fat actually survives, right? So the technique, so really I come away from that with respect. I respect the fat, I treat it with respect, and I get good results with it because of that. So essentially what I see on the operating table, like what I inject, because I've already washed the fat, and I have a device called a Revolve that gets rid of broken cells and gets rid of the red blood cells. So really all I have left at the end is the really good stuff. I've already filtered away the broken cells. And so what I inject into a patient is what I see 3 months later.
Wow.
Now, because we're injecting something that's been separated from the body already,
Right.
in order for it to live, it has to be nearby other vascularized tissue. So, for example, this is important when it comes to building a breast. So say a patient has an implant already, whether it's a tissue expander or a silicone implant or whatever it is, and she's like, I don't want this implant. Instead, I just want to inject my own fat. So I get this question a lot, right? Well, I can't in one step take out the implant and then fill it up with fat. It would completely fail. Because all that fat wouldn't have access to blood supply, just like planting that sapling in your garden, right? You need to have that fat injected into already vascularized tissue. I can't put it into a big open space.
Mm.
So that's where the repeat surgery of building a breast with fat grafting comes up, is I have to do a little bit at a time. So in a patient that already has an implant, the first step actually is to take out the implant, take out the capsule, and just go completely flat. Let that tissue heal. Then come back about 3 months later, and that's where I start what I call the foundation, like I'm building a house. So I start around the periphery of the outline of where I want the breast, and I do a layer of fat there, maybe build a little bit in the middle, and just kind of get enough in there just to kind of build a flat form. And essentially at that point, it's usually taking a woman who is concave in the chest from a mastectomy and just getting it flat is like
Yeah.
the surgery number one.
You're
And then
building the garden.
that's right. That's right. Exactly. And then come back usually about anywhere from 6 weeks to 3 months later and do another round, and keep repeating that until we get the breast mound that we want. So it requires a somewhat loose skin envelope. So something, if the patient has had a complete mastectomy with radiation and the skin is plastered to the chest, I would not be able to build a breast with fat grafting. But say another scenario where the existing skin is still there, it's a little bit pliable and movable, then I can build a breast with that. And to me, it's not as I don't get as much personal feeling out of this process as say a deep flap, where I just
Right.
I feel really great about that. But it's really not about how I what I get out of the surgery, right? Of course, it's what the patient gets out of it. So for the right patient who understands that this will be 4 or 5 surgeries, albeit outpatient procedures, with tiny little incisions and pretty well tolerated. As long as they understand that process, it works out really well, and we can get a soft, pliable breast that has good projection and looks natural, and they can avoid a big abdominal scar. So yeah, so that's how it's been working.
It's an option. It's
It's an option.
another option. And so this is what's so important, I think, is to offer patients these. You gave an excellent description. I learned a lot today.
Okay.
What I'm hearing from you, two important things. It's technique driven,
Yes.
and it is a process.
It
So
is.
that was very well stated by you. I want to thank you again for joining me today on the Deep Sea Foundation educational channel, because boy, did we get a lot of education today.
Great.
And again, just great talking to you, Dr. Eric Wimmers, who practices up at the Plastic Surgery Center in New Jersey, but he is also a part of the greater IFAR network of surgeons, which is the Institute for Advanced Reconstruction. Different ways to find you, and we'll put those in the description. Thanks so much for joining me today.
Absolutely. Thank you, Terry.
Mm-hmm. Take care.